Hi, everyone. I'm Dr. Aditi Joshi, and I'm the CEO of Ardexia. And in this series, we are trying to cut through the hype to explore healthcare innovation that actually works. In each episode, I talk with leaders and clinicians who are navigating digital transformation, whether in telemedicine, AI, RPM, EMR, and systemic change, sharing real stories from the trenches and practical strategies for creating healthcare change that people can trust. So let's get started. Today, I have the pleasure of speaking with Dr. Sarah Gebauer, a physician and a healthcare AI governance expert. She founded Validara Health to help organizations evaluate, validate, and safely adopt AI in medicine. With training from Stanford and UCSF, a background in national security working at RAND, and ongoing clinical practice as an anesthesiologist, she combines rare clinical credibility with governance expertise. She also writes a popular Substack on the realities of AI in medicine and consults widely with startups, investors, and health systems. I know Sarah because I'm part of her Slack group, which is medicine and machine learning, where it's a great resource to really learn and speak to other clinicians who are working in AI as well. So welcome, Sarah. I'm so glad to have you.
Thanks so much for having me. And I am thrilled to talk about these subjects. You're such an expert in digital health, and I think it'll be really fun to talk about digital health and AI and how these all come together.
Exactly. I'm excited too. So great. Let's get started. The first question I have. So, you're a practicing anesthesiologist. You founded an AI governance company and also this community. But what made you realize that healthcare really needed someone doing exactly this type of work?
Great question. I was at RAND doing AI governance work for national security issues, so a lot of biosecurity, trying to figure out how do we know if these new models are creating more risk or not? How do we know what kind of mitigations we might need to put in place and what would actually be helpful? And that is science. It's really evolving right now. That's really at the edge of science, but a lot of those key learnings are very applicable to medicine. How do we know that a lot of the tools that we're introducing are safe? We always want to maintain our Hippocratic oath and first do no harm, but we really also want to encourage innovation, and we want to make sure that the patients who might benefit from these tools have access to them when they are safe. And figuring out a way to do that and balance those key issues of innovation and safety is really what I am passionate about doing. The lessons that we learned from a lot of the national security experiments and issues have really come over to healthcare and just started to percolate into the ecosystem of AI governance. So we're just beginning to figure out how to apply those lessons into a healthcare setting.
Yeah, so I find this entire background being at RAND really fascinating, mainly because, in healthcare, we don't really get the benefit of all these tech companies and other people who know the type of technology they're using in depth. I know there are some clinicians who do know that, but we don't really understand that as well. When you were working there, what kind of risks do you see in AI that we should in healthcare really understand?
It's the AI risks are going to be different in every setting, of course. And national security, where we're looking at, how hard might it be to create something bad, and something bad might be a biological weapon, a chemical weapon, some kind of cyber attack, and not just how much easier is it for a human, but what's the possibility that the tool could create those kind of things on its own, for example. So the whole range in national security, and then what do you do with that? How do you make decisions based on that information? Is another really interesting piece. Um, One of my favorite parts was really being able to work with engineers that I worked with there as well, because you do learn so much in terms of what is the background and what is the kind of test that actually makes sense. What do you think you're testing for, and what do I understand it as a scientist? And we have that same disconnect in healthcare quite a bit. A lot of the hospital teams, their IT department doesn't necessarily have to talk to their clinical department very often, except if there's a broken computer. But in terms of the bigger picture, issues, the CIO level issues within a hospital, and when you're implementing AI, we have to do a better job of combining those and to make sure those key people talk to each other and understand each other's concerns. That was a major issue that we ran into at RAND, is just that AI by definition is so multifactorial and crosses professional boundaries in a way that other technology doesn't.
That's a really good point. And you're right about that. With the IT departments that I've worked with in health systems, even for telemedicine or RPM, which is infinitely less complicated than with the ethics around AI and how it works. And still, there would be some of that disconnect. But I know you had said earlier, there is a difference in the way that AI in healthcare is working in the lab versus the way that it's implemented into healthcare systems. And so, when we're talking about all these different teams, how do we actually bridge that disconnect? Are we there yet, or do we need a lot more work on it?
Yeah, we definitely need a lot more. It's one of the reasons I'm thrilled that you and your company are in this space because the implementation piece, we all know that healthcare has a last mile problem. And we also know it's well known in the venture world that if you want to make money, you should go somewhere other than healthcare because healthcare is notoriously hard to actually implement anything. It's very bureaucratic. There are a lot of rules for very good reasons, and things move very slowly. So part of that moving very slowly is for safety, which is wonderful. But in this kind of context, it means that there are other industries that are starting to move much more quickly and have systems in place than healthcare is able to. And in terms of the lab being different than the implementation, it has a lot of similarities with national security. Of course, the world is a huge place. People have access to a lot of different things. Knowing what to test for and how to determine whether that's a kind of test that actually is going to be meaningful to decision makers, whether that is a CIO, CMO, CEO of a health system, or a lawmaker or a legislator trying to decide what kind of mitigation should be put in place for biosecurity. We have to make sure that there is a continuous understanding from the engineer who creates the tests that we rely on to the clinical person who looks at them and understands them, and a feedback loop there as well to make sure that the tests are clinically meaningful. And then the same kind of feedback loop to the decision makers. So making sure that the clinical people have input into what kind of testing and what kind of information that they're getting back, that is the really important part for the patients. And then making sure that we're able to all talk together about these things. And these are skills that we're going to have to develop more and more as clinicians, as hospital staff, as hospital leadership in healthcare in order to make AI function well.
Mm-hmm. Yeah, this is a great segue to my next question because you do a lot of work with health systems, right? So if they're telling you to adopt AI, where do you see some of the green flags, right? Things that seem to really work well when people are trying to think through this problem or figure out this problem, and then things that really don't work well.
Yeah, every health system has such a different culture, and I know all of us who've worked in more than one hospital or more than one health system know this. But it's reflected in their AI policies often in a very concrete way. So there are some health systems that are very innovation forward and are willing to allow individual departments or even clinicians take some risks with their AI products that they implement. And other systems that are extremely risk averse and require multiple iterations and multiple levels before any kind of AI product is approved. And, as with most things, moderation is generally the best approach. So probably somewhere in the middle. But since we aren't getting a lot of federal laws and guidance like they are in Europe in terms of what does safety mean and what we need to be testing for, it means that every hospital is growing their own garden of evaluations and AI governance questionnaires, for example. And they're all trying to be very conservative because they want to make sure that they're not hurting anybody. So in terms of how far we have to go, we have a very long way until these are standardized, and that standardization process really helps the health systems because they don't have to come up with these governance questionnaires on their own, and also helps the vendors because they know what to expect when they're going into a new system.
That's great. So, there's been some movement on making these national AI governance. I know the EU has one. We have one here in the US now. How are they affecting healthcare? Is this something that we can actually use, or are there gaps in the way that it actually can be applied to medicine and healthcare?
Yeah, the EU's AI Act is still evolving, and we don't have all the details about how that will be implemented. But there are penalties of up to 6% of total worldwide revenue for the companies if they don't follow their own safety practices or what are considered to be adequate safety practices, even without evidence of harm. So you don't even have to prove that you were harmed to bring a lawsuit against them, and for the AI companies to have quite a large payout. In the US, most of the laws are really coming from insurance commissions. So these are guidelines for large health systems, especially those that self-insure, that they can't have bias in their tools. And that would apply to any kind of insurance. We don't allow people to be biased for a lot of different insurance products. And from the insurance commission standpoint, this is just an extension of the kind of expectations that they have for fair products throughout the marketplace. But for hospitals and health systems, this is one of the few things that they really have to make sure that they comply with, because they can be penalized. So it has been interesting to see how the lack of formal regulation has then popped up and transformed some agencies that normally wouldn't have had as much direct power over something like AI into one of the forces that we're really relying on the most.
That's really interesting, right? Because some of them are being forced to make it themselves. They do have these national guidelines or EU based on in that region, but it may not always help completely depending on how far it goes. So let's turn a little bit to the practical implementation, which is, I know that you do a lot of this for AI, which is why I was excited to talk about this. So, if you're talking to healthcare leaders, health systems, or any program that's running, and they're trying to adopt AI responsibly, what are three non-negotiables that you see as need to have before they can even start?
Yeah, this is a great question. In terms of what the hospitals need, they need to have a group of people who actually understand AI and can help shepherd the process with adequate time, and the administrative support and the hospital leadership support to be able to actually do the work that they have been tasked with doing. Um, they also need to have a system, both for the kind of questions they ask and for managing communication amongst the different parts of the hospital that are inevitably going to be involved in this kind of piece. And then also they need to have a feedback loop. So they need to have a way to get feedback from the people actually using the tools, from the clinicians, staff members, and make sure that they're actually using it. Is it working? Is it worth continuing to pay for? No one in a hospital has extra money to just throw around for no reason. And proving efficacy is really important. Talking to the people actually using it is crucial. And then can that information get back to the people actually creating the product and refining the product, so that they can have that kind of information transfer and make it into something that is positive? Obviously the EHR, we have a history of EHR implementation in medicine that a lot of doctors still have some resentment towards, because they felt like they were kind of being experimented on and they didn't get to really give feedback into what kind of EHR that they were made to use. And I am worried that if we don't radically change our approach to feedback and including clinicians and frontline workers and staff in how we use and refine AI, that we're going to have some of the same issues all over again.
Yeah, you and I speak the same language. I feel like we say this over and over again, but it's still very difficult to get that feedback loop right, or for people to be able to speak that language in a way that both sides understand, right? So clinicians can give that feedback, but it could be interpreted in a different way from healthcare leaders, by IT, et cetera. So, again, we're talking about this, and a lot of why we're still in a lot of pilot phases for digital tools. Well, I know AI is new, but this is going to be a problem with AI as well, is that we don't have the trust in these tools. And if you want these programs to go from, 15% of the hospital system using it to really 80%, we really need that clinician trust. And you hit on EMRs, which is really interesting because in general, right, you do have everybody using EMRs because they were forced to, but using these digital tools does not always lead to that. You don't always have to do it. So how do you see clinician adoption? How do we get physicians to trust and actually use AI tools as we move forward from hopefully this pilot phase to really making it part of clinical medicine?
Yeah, it's been a really interesting progression of clinician use. We saw the first way we saw AI adopted was in things like pre-authorization letters, things that everyone hates to do. They take time and they're very frustrating, and AI, frankly, did a very good job of them, better than most clinicians were able to. And then we saw the ambient scribe group really come in and do a lot a lot of physician recruitment and really focused on physicians as their primary customer, despite the fact that they were, really selling not to the physicians directly. For the most part, they were selling to the upper levels of management, but tried to create a product that the physicians would really love. And I think that's something that the more successful ones really focused on, that the technology is easy for the clinicians to use. It doesn't have a steep learning curve. And perhaps most importantly, it really took a burden off of the clinicians. And I mean, this is basic stuff, but for some reason in healthcare, we kind of forget that users like things that are easy to use. And, we want things that will make our lives easier. And that is true whether it's an app on the iPhone or an app in a hospital setting.
Yeah.
And then as we move forward, we're still really at, I would say, the place where most of the tools are in the admin section of, if you're going to separate AI tools into admin versus more clinical tools, we're still mostly using admin tools because clinicians feel like those are safer. They don't have any clinical decision-making properties for the most part, and they are just more obvious use cases. So I think the admin side will continue to see fairly rapid adoption. The clinical side is always going to be harder because of that trust piece, and also because the physician's perceived need for some of these tools is very different from the decision makers' perceived need for some of these tools. And so I think that is a major factor also that will have to be addressed in terms of making a tool that can serve both kinds of users at the same time, both the people buying and the people actually using it. Those will be the most successful every time.
Yeah, thank you for that. And I think it's a really important point what you said about the perceived usefulness and what on both sides, what is perceived as useful on both sides, because I think that's a really profound point. A lot of physicians do not want to be told that there might be a safer way for them to go through clinical decision making. I think part of what happens is that it is not really a great way to market to an entire profession to tell them that, they're not doing their job well enough. So there has to be a way to say, no, it's not that you're not doing it well enough. This can take off some of that burden. So I really wanted to second what you were saying about that. I think that's really interesting. But on the same side, it isn't going to work for everything. There are things that our brains do that AI still cannot exactly mimic or generate, as we talk about. So I want to take the last few minutes, really talk about, when you're talking about AI good governance, and we're talking about a healthcare. So let's say it's 5 years from now, all of these problems that we're talking about, which honestly, like you said, are very much simple problems, but they have incredible impact. What do you see success looks for in AI governance in healthcare for you?
What does success look like for AI governance in healthcare? I am really excited about AI governance in healthcare because I really think that it can help smooth the way to adoption of tools that can be life-changing for patients. I think all of us who are physicians, it's nice to have, to not have to type a note in, but what we went into medicine for and what we get really excited about is something that can help a patient in a way that was never possible previously. And that to me is the promise in 5 years from now, is that we have figured out how to do AI governance in a way that minimizes the time for good tools to get adopted and into the ecosystem and keeps patients safe, and that it's all run in a very smooth way that doesn't hold up solutions unnecessarily that could really help all these patients that we really, really want to help. I mean, if you want something to get adopted, create something that patients have a huge, huge need for, and doctors will use it because they truly do care about their patients.
Yes, 100%. That's how you get them to use it, which, whether it's by forcing them or showing them the evidence. I completely agree with you. Thank you so much for that. So just for the last quick question, if you were to speak to all of the digital health leaders, all of the clinicians, physicians out there right now, what do you want to tell them about AI and healthcare that they should know, that you feel is really important right now for them to know?
The most important thing to know is that you have to involve clinicians in your process of creation and feedback loops. It's very easy to create a product with only engineers who are wonderful, but if it's not used by clinicians, then all that promise that I just talked about, all those solutions for patients, they're not going to get adopted. And everyone is going to lose. The company that created them will lose, and most importantly, the patients will lose. So we need to have a closer relationship with our engineering colleagues, and we need to do better upskilling of all the staff members in the hospital so that they can identify what solutions would be best served by AI, and also to create the kind of AI solutions that are most helpful and meaningful for the bottom line, which for physicians, the bottom line is, does it help my patients or not?
Thank you for that, Sarah. It was such a pleasure. You're always such a wealth of information. I want to thank you for being here, and for everyone listening. This is Dr. Sarah Gebauer. Please follow her work at Validara Health and her Substack, which we will link to. For everybody else, this is Aditi Jacker, Aditi Joshi. Thank you for listening to our conversation, Ardexia. If this conversation sparked ideas for you or about your own healthcare innovation challenges, please follow us. We're going to be talking more about these topics, as well as building out what the healthcare of the future is. Till next time, let's creating the healthcare change people can trust. Thank you very much.
Thank you.